Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Irim Salik. She's a pediatric anesthesiologist. Today's Kevin MD article is The Hidden Danger in Pediatric Dental Offices. Irim, welcome to the show.
Thank you so much. I appreciate being here. It's a pleasure and an honor. Thank you.
All right, let's start by briefly sharing your story, then we'll jump straight into your Kevin MD article.
Sure, absolutely. So I am a pediatric anesthesiologist. I work at Weill Cornell Medical Center in New York City. A mentor of mine mentioned to me that we should look into sedation for outpatient dental procedures in children. And while we do know that anesthesia is exceptionally safe in children, it's actually safer for a child to have general anesthesia than for them to get in a car and drive to get gas or groceries with their parents. What we find is that if you look at the literature and if you look at, the media reports, that there are rare cases of death or permanent neurologic injury that can occur during outpatient sedation for dental cases. This is not exclusive to dentistry, but I wanted to focus on dentistry because it involves children.
You talk more about that, of course, in your Kevin MD article. But before you talk straight into that
Oh,
article, just give us a sense of how often are pediatric dental procedures accompanied by a pediatric anesthesiologist like yourself?
so that's a great question. So I talk about procedures that occur in an outpatient dental setting. And to
Yep.
be honest with you, it's very rare for a pediatric anesthesiologist to be present in an outpatient dental setting. In the hospital all the time.
Hmm.
In an outpatient setting, there's a shortage of anesthesiologists and there's a shortage of resources. So it's very rare that it happens. The people that give anesthesia in the dentist office in an outpatient setting are either the pediatric dentists themselves, and either give like laughing gas or nitrous oxide, which is considered very safe, or medication by mouth. And then there are nurse anesthetists or dental anesthesiologists, or there are some physician anesthesiologists, although it's rare. And then there are oral and maxillofacial surgeons who give their own anesthesia, and they often start an IV. So there are different practitioners, but to have a pediatric anesthesiologist in an outpatient dental setting, it's relatively rare.
All right. And tell us about some of the hidden dangers that we need to know about that the literature says.
Yeah, so again, I would like to stress that anesthesia is exceptionally safe and these events are very, very rare. But the point of this process is I think it's important for physicians like myself to highlight and to speak out about that there should be a commitment to improving quality and safety in the outpatient setting. So some of the problems that occur are airway compromise, respiratory depression or hypoventilation, respiratory or cardiovascular arrest. There are instances where a patient is inadequately monitored. The personnel that is taking care of the patient don't have adequate rescue capabilities for the airway. There can be a delayed recognition if monitoring equipment is not adequate. And then emergency response can be inadequate as well. And this eventually leads to catastrophe where a child can develop a permanent neurologic injury or death.
That, of course, is the biggest fear that any parent has whenever they bring their child in for some type of outpatient dental procedure that requires anesthesia. And like you said, it's exceptionally safe, but sometimes you hear about these tragic cases in the
Right.
news. So
Right.
in general, how often do these catastrophic events happen?
So that is actually the crux of the problem. We don't know. We only hear about them in news reports and in some closed claim analyses, but we actually don't know how often they occur. So my message would actually be that it's important for us to be evidence-based, and data-driven. So in medicine, we report anesthesia-related outcomes to different registries. We have a national registry where we collect anesthesia-related data and, we benchmark our outcomes. These are, the NACOR registry and, the MPOG registry, where anesthesiologists that are participating and hospitals that are participating, will share their data. So it helps anesthesiologists meet quality reporting requirements. It also enables outcomes research that improves quality and safety of care. But for the dental industry, there is no comprehensive national database that captures outpatient dental procedural volume. So we have no idea how many anesthetics are occurring, and we have no idea how many adverse events happen nationally. We don't know. So we hear about them in news reports, and then I've actually tried to do, a deep dive
Mhm.
to get to get some information about exactly what happened, and it's very, very challenging. A lot of these cases, if they go through a malpractice suit, they are sealed through an NDA. So it's very challenging to get this information. So that is the crux of the problem. And that is what I think we have to change about the way we practice. That I believe that dentists that practice in an outpatient setting should report their anesthetic cases to a national registry so that then we're able to collect this data,
Mhm.
analyze it, and collate it, and try to identify systemic risks that occur and patterns that we see. The reason why anesthesia has become so safe is that when we have an error, a near miss, or a fatality, we conduct something called a root cause analysis. We conduct a root cause analysis, which is essentially a systematic, structured process that allows us to identify the underlying reasons why an adverse event occurred. We're not trying to assign blame, but we're trying to prevent this event from occurring again. And we have no such corollary in the dental industry.
So, what are some of the common procedures that may potentially expose a pediatric patient to risk from some of these anesthesia complications? Is it something as common as a wisdom tooth extraction?
Yes,
What are some
yes.
common procedures that you're hearing about?
A wisdom tooth extraction, a child who's even having, like, a dental cleaning, a cavity fill that requires anesthesia, multiple cavities filled. So the most common reason why a child has to go to the dentist is that they're either not brushing their teeth enough, or their parents are putting them to sleep with a bottle of milk or juice. And so if you're not cleaning the teeth, they develop like a massive sort of a decay. And so in a hospital setting, what we do for these cases is we secure the airway, with an endotracheal tube. In the dental office setting, that may or may not happen depending on who's providing the
Mhm.
anesthesia. And so without a secure airway, there's a very fine line between mild, moderate, and deep sedation. And when that line is crossed, that's the time when catastrophe can strike. And if there's not an adequate recognition and response, that's the time when airway compromise can lead to a cardiac arrest. Again, as I said, this is very rare, but it's something that I think it's something that parents should be given adequate informed consent
Mhm.
about, and they should be told about the risks and benefits involved. Office-based anesthesia is something that is here to stay forever. There's no way, the costs and resources are so prohibitive that there's no way that we can care for all the children who need to be seen by the dentist in a hospital, or
Mhm.
or sort of, in an ambulatory surgery center. And we know that anesthesia is we know that it's going to be safer in these settings because the backup systems in place are so robust. In an office-based setting, we don't have those same backup systems in place. And that's what leads to trouble.
Now, in these catastrophic cases that you've read and studied, are there any common themes among those cases that led to that tragic result?
Common themes among the tragic cases are that the practitioner doesn't respond in a timely fashion. Monitoring equipment is not available. Capnography, or end tidal CO2 monitoring, is the gold standard for, like, either, a deep sedation or general anesthetic, or even, for mild or moderate sedation. It's not available in every dentist's office. Emergency airway equipment, the ability to do high quality cardiopulmonary resuscitation, or CPR, is absolutely essential. And it's important that someone in that room must be able to do adequate CPR. I'm not sure that there is someone in the room that can do it. By the time someone calls 911 and an ambulance arrives, the child or the patient may already be in extremis or past the stage of being helped. So, and there are times when at a dentist's office, you're in a rush and you give a little bit of sedation and it's taking too long or the child is not responding in an adequate fashion. And you give a little more and you give a little more. And by the time you know it, the child now has an obstructed airway.
Hmm.
And now you have to have someone who can manage the airway. And as I said, normally what we find we've moved away from, the single provider model where the surgeon who is performing the procedure is also providing the sedation. That is very, very, very rare. It doesn't occur because we realize, the inherent risks that are present with that. But even having an independent anesthesia provider, we find that adverse events occur. And it leads us to believe that this is a systems-based problem. But again, without the data, without the evidence, we just don't know.
Mm.
Which is why I think it's so important for dentists to be part of a national registry and report their data so that we can try and discern exactly what the risks and patterns are when a catastrophic event occurs.
So, for parents who are listening to you now, and if they're bringing their child in for, say, a wisdom tooth extraction, either to their dentist or oral surgeon, is there a checklist of questions they should be asking that office to ensure that the anesthesia is safe?
Yes, absolutely. I think it's important to know who will be providing the anesthesia for the case. I think I have to give a lot of credit, to the dental anesthesiologist. This is a fairly new specialty since the late 1970s, early 1980s is when the residency, for dental anesthesiologists actually started. So these are dentists that then do a 3-year residency in anesthesiology. They are exceptionally skilled and they have done a lot to make the practice of office-based sedation much, much, much safer for children. But you should know who's providing anesthesia. You should know, is there backup airway equipment, emergency medications available? Is someone available who can do cardiopulmonary resuscitation in an emergency? What is the plan in an emergency? I
Hmm.
think it's important for parents to be aware. Also, what type of anesthesia is about to be given? Are we doing mild, moderate, or deep sedation, or even, a general anesthetic? Also, for parents who have children, I think it's very different when your child is healthy versus if your child has underlying medical problems.
Mm.
If your child has a lot of comorbid diseases or conditions, I think it's prudent for parents to ask the question, should this case be done in a hospital setting? So if there's a problem, there is a recovery room nurse or potentially, an ICU bed available if an event occurs where my child needs a higher level of care, especially if your child has comorbid diseases or conditions.
One of the things that you mentioned was basic monitoring equipment like end-tidal carbon dioxide monitors. So simply asking if the office has one of those, would that
Yes.
be on the checklist in terms of?
Absolutely. Oh, yes. I think that's very important. I think if your child is receiving anesthesia, there should be end-tidal CO2 monitoring. That's an excellent point. Thank you. Yes.
We're talking to Irim Salik. She's a pediatric anesthesiologist. Today's Kevin MD article is The Hidden Danger in Pediatric Dental Offices. All right, let's end with some take-home messages that you want to leave with the Kevin MD audience.
I would like to reiterate to parents that anesthesia is exceptionally safe. I would like to reiterate that you should be an informed consumer. If your child needs to receive anesthesia in a dental office, you should ask the important questions of who is providing the anesthesia, what type of monitoring equipment is available, what type of emergency preparedness is the office staff available of conducting. Is there any end-tidal CO2 monitoring? That's an important question. And I think it's important for the dental industry to know that reporting their data to a registry would go a long way in improving quality and safety for children that receive outpatient dental care. And I know it would require, a culture change, a dramatic change in the culture of the
Mhm.
way that the industry practices, but it would be an extremely positive step towards quality improvement and patient safety.
Irim, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thank you so much. It was a pleasure. Thank you.